The study was designed as a chemotherapy trial in patients with clinically high-risk disease. So all patients were candidates for adjuvant chemotherapy based on their clinical assessment. And then we had put in Oncotype DX Recurrence Score for identification of some patients with low-risk disease who should omit chemotherapy based on their very low genomic relapse risk. The trial was run in Germany, from 93 centers over Germany, and in 2009 to 2011 about 3,200 patients were screened for participation in trial. All patients had hormone receptor positive HER2 negative disease, and if patients had hormone receptor positive HER2 negative disease, then recurrence score was tested, and in patients with up to 3 positive lymph nodes and very low genomic risk, patients were treated by endocrine therapy, and all other patients, so patients with more than 4 positive lymph nodes or patients with recurrence score more than 12, all these patients, as well patients with triple negative disease, with hormone receptor negative disease, all these patients were randomized to the chemotherapy equation. For the chemotherapy equation, the primary endpoint of the study was comparison between efficacy between two chemotherapy regimens by disease-free survival defined as time from randomization to any event defined as relapse or non-invasive relapse or death or secondary cancer. And we have planned prospective analysis also for the evaluation of prognostic impact of recurrence score in this clinically high-risk collective. And so now, today we have presented this endpoint on 5 years disease-free survival based on recurrence score. We have a lot of retrospective evidence for several genomic tests from prospectively run trials, which were reanalyzed after many years of follow-up regarding prognostic effect of genomic tools. But what do we need for today from our today practice? We need the data how the genomic tools are performing in our today practice in setting of our today's decisions in adjuvant therapy, because these decisions are another compared to 10 years ago. So within the PlanB trial, this is the first worldwide data and prospective evidence on impact of genomic tool in patients with clinically high-risk disease, because we have also excellent data from a prospective trial run for recurrence score from the TELERIC study from the US. But in this study, only patients with node-negative disease, they had recurrence score, and if they had very low genomic risk, we have the data that these patients are doing very well. My question in the clinical routine, is it possible in a patient with clinical indication for chemotherapy, can I omit chemotherapy based on low genomic risk? This data were presented for the first time from our explorative analysis from the PlanB trial.